speaker is Dr. Divya Rao, Harnessing AI, that's automated imaging to prevent ROP blindness. ROP is a hot topic. It's the third presentation, I think, on ROP we have in this session.
Good afternoon, everyone. Thank you so much for joining us today. I'm Divya Rao, and I'll present our analysis on a real-world study that evaluated an AI for ROP screening. Here are my disclosures. I lead the AI development at Remedio, where this technology was developed along with the KidROP team led by Dr. Anand Vinekar, and this was conducted under the BIRAC grant. India has 3.5 million preterm babies born annually, the highest anywhere in the world, and is the leading cause of preventable infant blindness. And compounding this problem is that there is an acute shortage of ROP specialists in India, less than 200. So technology like AI can really help bridge this gap and allow for a paradigm shift in screening using this technology. So essentially, it can empower nurses, trained operators, and even neonatologists with a tool that can help them refer babies with ROP, and this can be combined with or without teleophthalmology. So we developed an ROP algorithm that looked at presence or absence of disease. We used over 200,000 wide field images from multiple camera systems that were obtained from the KidROP program. And we used an assistive model to actually sort out the temporal images. We used this for training. The ground truth came from the KidROP program. And we essentially also looked at how this model did on internal test data sets, and the results were very promising. But the next step was really to look at how this model was actually doing in the field. So to evaluate this model, image-based automated AI to screen for ROP in premature babies. We looked at 329 at-risk infants who met the inclusion and exclusion criteria. This was conducted across several screening centers which use multiple camera systems, and we divided them into 1, 2, and 3, where Neo cameras were used, RedCam 3, as well as RedCam Shuttle. We compared the AI that uses temporal images for diagnosis to screen presence or absence of ROP against 2 benchmarks. The first benchmark was field diagnosis by expert graders, and also we looked at comparing the AI against consensus image grading by by 2 ROP trained graders, and was also adjudicated by an expert. So we recruited 304 at-risk infants with a mean birth weight of 1,690 grams with a gestation of 32 weeks. And as you can see here, when we compare the algorithm against the field diagnosis or consensus image grading, the sensitivity and specificity were comparable, over 90%, and the specificity close to 82%. The false negatives were primarily stage 1 ROP, and there were no missed cases of AROP. And the Cohen's kappa amongst the graders were very promising at 0.84. The representation of Neo cameras was more. As you can see, majority of the data was from this system with comparable data across the 3 and the Shuttle. And the sensitivity across all were encouraging, but the sensitivity was highest on the Neo camera system, and the specificity was marginally lower on this system. Here is a visualization of the results of true positives. As you can see, the heat maps point to the area of diagnosis. It acts as a visual check. And on the left, is an example of a false negative case, which was a stage 1 ROP case. In the middle is a false positive case, where you see the heat maps over the vascular areas, and on the right is a true negative case. So the ROP AI screening algorithm demonstrated encouraging results, achieving sensitivities and specificities exceeding 90% and 82%. We use very stringent benchmarks, both field diagnosis as well as image grading. There's promising generalizability across the camera systems. The false negatives were primarily missed stage 1 disease in zone 3, and the false positives could be further minimized by reducing the number and quality of images captured on the temporal quadrant, as the AI here needed only 1 image to be positive, and this was the real challenge for the AI. The strengths, this is a real-world prospective validation, one of its kind, the first in India, and as I mentioned, we use stringent benchmarks, and we use multiple camera systems. One of the limitations was equal distributions across camera systems, but this was practically challenging because the Neo was the one which was used most in the field. And as the next steps, we are looking to also validate a treatment triaging model that could specifically also pick up plus disease, and this is ongoing. So just to